She is a graduate of the University of Michigan Medical School and completed both her pediatric residency and chief residency at CCHMC. Dr. Yanaka has served as the Associate Program Director of the Pediatric Residency Program since 2011 and is the Medical Director of A6CN, a 41-bed unit that serves as a primary inpatient home for patients admitted to the hospital medicine service. From a scholarly perspective, she utilizes her formal training in medical education and quality improvement to enhance family experience and optimize communication with patients and families. Not surprisingly, Dr. Yanaka spends considerable time working on institutional level community health initiatives, which reflects her passion for diversity, inclusion, and health equity. In fact, the number of leadership and management and service-oriented activities with which she is currently involved supersedes many senior level faculty. She serves as either a team member or coach on a number of quality improvement teams, not just in-house, but also at the national level. Dr. Yanaka has also served on a number of boards in our very own community, focused on improving the lives and well-being of children and their families who reside in those communities. I would call Dr. Yanaka an influencer, and with her delivery of the keynote address to the class of 2022 White Coat Ceremony at UC College of Medicine, I believe she has begun to influence an entire generation of future physicians. So let's provide Dr. Yanaka with a warm welcome.
Thank you, Jareen, for those really kind words. I really appreciate it. I will go ahead and share my screen with you all. All right, can you all see that?
Yes.
Fantastic. All right. So the title of my talk is Truth and Tension, Reflections on Racism in Medicine. And I just want to provide a bit of context as to how I came to really want to talk about this topic. I have no conflicts of interest to disclose. So I think as we reflect on our core values in medicine, I think these are core values that many of us are very familiar with. I think about patient and family experience, teamwork, compassion, safety, dignity, and respect as common core values that we are very proud of within the field of medicine. But at the same time, I think about some really profound inequities and disparities among our patients and families that we care for. For example, we know that children and adolescents from poor and predominantly Black and Latinx neighborhoods spend significantly more days in the hospital than their counterparts that come from more affluent, predominantly white neighborhoods. We know that there are strikingly disparate rates of morbidity and mortality in Black men and women who have cardiovascular disease, stroke, and diabetes. We know that there are marked disparities in insulin treatment methods and treatment outcomes. In fact, insulin pump use is higher in white children than in Black and Latinx children, respectively, even after we adjust for gender, age, diabetes duration, and socioeconomic status. We also know that Black men have the highest rates of prostate cancer deaths. And in fact, in 2017, the death rate in Black men was greater than 2 times that of white men. We know that Black mothers have the highest rates of premature births and are 3 times more likely than white women to die from pregnancy-related complications. Black infants are 2 times more likely to die before their first birthday than are white infants. Black children who present to the emergency department with acute appendicitis receive opioid meds at less than half the rate of white children, and Black children with moderate pain are less likely to receive any pain medication. And a recent study that was just published a couple of weeks ago shows that healthy Black children have greater than 3-4 times the odds of dying within 30 days after surgery, and an 18% relative greater odds of developing post-operative complications compared to white children. And I would be remiss if I did not mention the current global pandemic that has impacted all of our lives, COVID-19. When we look at the comparisons of COVID-19 cases, hospitalizations, and deaths, we see that Black individuals are 2.6 more times likely to be diagnosed with COVID-19, 4.7 more times more likely to be hospitalized, and greater than 2 times more likely to die from COVID-19. And so when I think about our core values that we espouse, that we are so proud of within the field of medicine, I think it's important that we acknowledge that our identity, our true identity, does not fit the bill, and there's a tension there. And I think it's important that we explore this tension in order to really move forward and change the outcome for our patients and families and future generations. So my learning objectives today are for all of us to develop an understanding of race as a social construct, to develop to understand and define the various levels in which racism manifests in our society, to appreciate the connection between systemic racism and social determinants of health. And my focus for this talk is really to examine the history of anti-Black racism in medicine, with a particular focus on the dark history of exploitation of Black people for the sake of medical research. So let's start off by talking about what race actually is. So when we talk about the history of race, it's important to have a sense of where the story begins. So the concept of race was historically all about trying to divide humanity. And it emerged as a product of colonial enterprises of European powers in the 16th century. And it really was an impetus due to the Atlantic slave trade. This was a way to incentivize the categorization of human groups to justify the subordination of African slaves. However, in 1767, we had the first classification of humankind based on distinct races. And those races were grouped into 4 specific categories: the red race, the white race, the yellow race, and the Black race. As you will see on this chart, there are characteristics that are assigned to each race category, as well as an assumed description of what each race is regulated by. As you can see with some of the adjectives that are used to describe the white race compared to the Black race, there's a stark contrast there, with Black people being described as females without shame, crafty, sly, lazy, cunning, lustful, and careless. Fast forward to 2003, which was the year in which the Human Genome Project was completed, and we learned that there is no specific gene, trait, or characteristic that distinguishes all members of one race from all members of another. And in fact, we are all 99.9% the same as human beings. There's more variation within groups defined by race than there is across racial groups. Francis Collins, who is the head of the NIH and was the lead of the Human Genome Project, said this very eloquently: a true understanding of disease risk requires a thorough examination of root causes. Race and ethnicity are poorly defined terms that serve as flawed surrogates for multiple environmental and genetic factors in disease causation. Research must move beyond these weak and imperfect proxy relationships to define the more proximate factors that influence health. So then we still have this question: what exactly is race? Well, we know that in the United States, we define race in 5 broad categories, but it's important to note that someone who is considered Black in the United States might actually be considered colored in South Africa or considered brown in Brazil. Race is not necessarily the same across the board. So again, what actually is race? It's important that we understand that race is an ideology that has social and political implications. And it's profoundly important that we understand that it is rooted in the social construct that tiers human dignity, worth, and power. So when we talk about race as a social construct, it's important to know what this actually means. So a social construction is a concept that is created or invented by individuals of a society, culture, or institution. It exists solely based on a society's acceptance of a specific concept. And it's a societal agreement to, number 1, behave as if this concept exists and follow certain conventional rules. So when we talk about racism, what we really mean is that it is an umbrella concept that encompasses specific mechanisms that operate at the intrapersonal, interpersonal, institutional, and systemic levels of a socio-ecologic framework. and it is an aspect of the social context and is linked with differential power relations among racial and ethnic groups. So as we describe race as a social construct, I believe that race is also a power construct. So as we try and dissect the 4 levels of racism, it's important to understand what these actual levels mean. So intrapersonal racism, otherwise known as internalized racism, is the acceptance of negative messages about one's own self-worth and abilities. Interpersonal racism, otherwise known as personally mediated racism, is prejudice, implicit or implicit biases, or differential assumptions about someone's abilities, motives, or intentions of others related often or rooted in stereotypes. Institutional racism is the differential access to goods, services, or opportunities based on race that exist in specific institutional or organizational policies or practices. But where I really want to spend my time for this talk is talking about systemic, or in other words, structural racism. So when we talk about structural racism, it's important for us to understand that this is the driver of inequities. Structural racism is the ways in which societies foster racial discrimination via mutually reinforcing and equitable systems such as housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice, to name a few, that in turn reinforce discriminatory beliefs, values, and distribution of resources reflected in history, culture, and interconnected institutions. I think we within medicine are very familiar with the term social determinants of health, which is defined as the conditions in which people are born, grow, live, work, and age that shapes health. But it's important that we understand social determinants of health within the context of structural racism. So here are categories of social determinants of health that include economic stability, neighborhood and physical environment, education, food, community and social context, and healthcare systems. So as I now will transition in this talk, I'm going to really try and make the connection between social determinants of health and examples of structural racism here in our society. So let's start off looking at an example that is really connected to economic stability and neighborhood and physical environment. So after the Great Depression, there are a series of programs that were implemented as part of the New Deal. One of those programs was the National Housing Act that was passed in 1934. And within this legislation included the establishment of the Federal Housing Administration. And this was actually a government-sponsored system of segregation which promoted via refusal to insure mortgages in and around Black neighborhoods. And they did this through the creation of color-coded maps to delineate neighborhoods worth investing in for lending purposes. Neighborhoods that were denoted by green were the most desirable neighborhoods, and neighborhoods that were in red were the least desirable or the more risky neighborhoods to invest in. And no surprise, areas that were most frequently denoted as red were Black inner city neighborhoods. This is an example of what one of these maps looked like. And I think this really is all about this concept or practice called redlining. So redlining is a systematic refusal or denial of services by public and private sector agencies that directly or through the selective raising of prices. So this is most commonly seen in mortgages, and in the Fair Housing Act of 1968, this practice was made unlawful, but examples of this practice still exist today. So for example, I think we're all familiar with the predatory lending by large banks, with Wells Fargo being one that was definitely in the news. And Wells Fargo targeted Black communities intentionally for subprime mortgages. And this practice is called reverse redlining. So the reason why I bring this up is because we know that home ownership is often referred to as the American dream and is vital to many families in terms of building wealth. And we know that wealth is generational. So what is the impact of a practice like a practice like redlining on the Black community. Well, we know that in the average US metropolitan area, homes and neighborhoods where the share of the population is majority Black, homes are valued at roughly half the price as homes in neighborhoods with no Black residents. We also know that differences in home and neighborhood quality do not fully explain the devaluation of homes in Black neighborhoods. And we also know that there is a positive and statistically significant correlation between the devaluation of homes in Black neighborhoods and the upward mobility of Black children in metropolitan areas with majority Black neighborhoods. This is a graph that shows the denial rates for home loan applications by race. And as you can see, Black people are denied home loans more often than any other race category. And Black people are less likely to own homes as a result. When we look at neighborhood and physical environment, it's important to talk about environmental injustice. And this exists when the disproportionate environmental burden rests on the shoulders of marginalized communities. And these burdens are often a result of policies or practices rooted in systemic racism. Environmental racism are the laws and policies that deliberately target communities for locally undesirable land uses and lax enforcement of zoning and environmental laws. It leads to communities being disproportionately exposed to toxic and hazardous waste based on race. Several contributing factors lead to this, including intentional neglect, alleged need for pollutant receptacles in urban areas, and a lack of institutional power and low land values of people of color. It's important to know that environmental racism is inseparable from racial segregation, and we'll talk about an example that impacted the health of an entire community. So Flint, Michigan has a population of 95,000. It is majority Black at 53.7%, and the median income is just over $27,000. In 2014, the city decided to switch the drinking water supply from the Detroit system to the Flint River as a cost-saving measure. The water source was not adequately tested or treated, and it resulted in significant water quality and health problems for Flint residents. And these problems were blatantly ignored and discounted by elected officials for 18 months. Dr. Hannah Atisha and her colleagues published a paper looking at the elevated blood levels in children associated with the Flint drinking water crisis. And what they found was that the incidence of elevated blood lead levels increased from 2.4% to 4.9% after the water source change. And neighborhoods with the highest water lead levels experienced a 6.6% increase. There was no significant change in lead levels in families that lived outside of the city. And they noted that disadvantaged neighborhoods had the greatest elevated blood lead level increases, which led to this particular issue being declared a public health emergency. 9,000 children were supplied lead contaminated water for 18 months. And as of yesterday, the city of Michigan actually settled with $600 million set aside to compensate the victims and their families for what they have gone through related to the Flint water crisis. Let's look at education. So we know that the Brown versus Board of Education legislation that was passed by the Supreme Court declared racial segregation of schools unconstitutional, and yet there are still profound inequities along racial and ethnic lines. So we know that school districts remain largely segregated by race. We know that school districts still remain largely segregated by income. And we know that there are profound inequities in funding based on districts and neighborhoods. For example, in 2016, school districts that primarily serve students of color received $23 billion less in funding than mostly white school districts, despite serving the same number of students. And white school districts enroll approximately 1,500 students, which is half the national average, while white school districts are overcrowded and serve over 10,000 students, which is 3 times the national average. And then community and social context. And I think this particular category is incredibly important and speaks to the moment that we are in our country. So we know that the recent murders of George Floyd, Breonna Taylor, and Ahmaud Arbery, certainly along with the murders of others like Elijah McClain, Tamir Rice, and Timothy Thomas, who was murdered here in Cincinnati, really expose our country's long, dark, and shameful history of racism. And I think in addition to the chasms that we see in economic and educational opportunities, we know that when we think about structural racism, more often than not, it renders the Black community guilty. We see it in the disparate rates in terms of mass incarceration. And this is something that we all have to really carry a mantle to really make a change. So let's look at the data. So we know that roughly half of those who are fatally shot by law enforcement are white, but Black Americans are fatally shot at a disproportionately higher rate compared to their representation in the United States. We also know when we look at the prison population that even though white individuals make up the vast majority of our population, they are underrepresented in the prison population. In contrast, African Americans make up less than 13% of the population, but account for a third of our prison population. And then we know Black men are roughly 5 times more likely to be in prisons than our white counterparts, and nearly 13 times as likely within the 18 to 19 age group. Let's look at our handling of substance abuse epidemics. There's been a differing perspective and approach based on the predominant racial group who has been impacted. One approach is empathy and medicalization. The other approach is disregard and criminalization. So if we look at the crack cocaine epidemic, which was synonymous with the war on drugs, we know that crack cocaine use was viewed and portrayed as a moral failure or dysfunction within the Black community. Powdered cocaine use, which is more prominent in white affluent communities, is seen as more socially acceptable. The Anti-Drug Abuse Act of 1986 imposed legal penalties that criminalized powdered cocaine and crack at a ratio of 100 to 1. So what does that mean? It means that if an individual was found to have 5 grams of crack and another individual was found to have 500 grams of powdered cocaine, both would receive the same mandatory 5-year minimum sentence. So we know that this approach was racially biased, and this response certainly was a driver of inequities and mass incarceration that we see today. In contrast, the opioid epidemic has been declared a public health crisis. In the 2010 substance abuse and use, there was a paradigm shift in how we thought about it due to the impact on suburban and rural white communities being the key driver. Addiction, rightfully so, is now framed as a disease, although I think there is still a distinction between urban heroin addiction and suburban and rural prescription opioid addiction. Significant resources have been allocated towards research, education, prevention, and treatment. In fact, HHS has actually awarded greater than $9 billion towards these efforts. So now that we have talked about the backdrop and made the connection between social determinants of health and structural racism, now we're going to talk about how structural racism has really manifested through medicine, with a specific focus on our history of abuse within the research sphere. So racism in medicine has truly been laid bare by the well-documented exploitation of Black people by the medical community. And this abuse and mistreatment has truly resulted in a deep mistrust of healthcare providers that is both legitimate and real. The examples of medical abuse, exploitation, and experimentation abound and include the use of Black bodies during antebellum period for medical experimentation, the dehumanization of Black bodies via grave robbing for medical school cadavers, putting Black bodies on public display in zoos, in the circus, and the like. Eugenics, which is the forced sterilization of Black people via pharmacologic and surgical methods. In fact, surgical sterilization is often referred to as a Mississippi appendectomy. Intentional injection of Black subjects with harmful pathogens and toxins. Intentional exposure of Black children and adults to non-therapeutic and harmful drugs, substances, radiation, and surgical procedures. Intentional withholding of available treatments from Black subjects. And the use of Black bodies, tissue specimens, and beyond without consent. And medical experimentation and abuse of Black prisoners. Scientific racism is really what propagated a lot of these medical abuses. And it is the belief that empirical evidence exists to justify the inferiority or superiority of a specific racial group. Examples of this include medical journals that were published as pro-slavery propaganda during the antebellum times, which highlighted specific conditions or deformities as proof of the inferiority of Black people. Experimentation and abuse is often rooted in the need to provide evidence or proof for racist beliefs about Black people, which include that Black people are not intelligent, that Black people are culturally unevolved, that Black people are lazy, that Black people do not feel or experience pain, that Black people are non-compliant, that Black people are hypersexual, and that Black people are violent. So we're going to walk through all of these examples and to give you a sense of how exploitation in medical research has really harmed the Black community. So we'll start off by talking about vesical vaginal fistula repairs in enslaved Black women. So Dr. J. Marion Sims was an Alabama surgeon who was often revered as the father of gynecology. And he was credited for developing a surgical technique to repair vesical vaginal fistulas, which I will refer to as VVF moving forward, which is a complication of childbirth in women. Enslaved Black girls and women were actually at higher risk of developing VVF due to nutritional deficiencies and their young age at the time of pregnancy and delivery. And Dr. Sims conducted experimental operations on enslaved Black women for 4 years between 1845 and 1849. It's important to know that enslaved women were property, right? So they could not consent, and permission to operate and use them as, exploit them for these procedures was granted by their slave owners. The motivation for slave owners was number one, if enslaved women could not work on the fields or have children, their value was markedly diminished. So they had an incentive to allow these women to be exploited by Dr. Sims. He used the bodies of 7 enslaved Black girls and women as experimental subjects. And his first operation occurred on an 18-year-old woman named Lucy. And the women were described as being on their knees, completely naked, while several other physicians watched Dr. Sims perform the procedure. He performed 30 operations on one enslaved Black woman alone, anarcha, without any anesthesia, even though ether anesthesia was first discovered in Boston in October of 1846, a year after he began his experimental surgery. In June of 1849, he successfully completed the VVF repair using silver wire as a suture material, and he subsequently performed the perfected procedure on white women with anesthesia. Dr. Sims certainly upheld the racist idea that Black people do not feel pain to the same degree as white people, which is a notion that still persists today based on some of the published evidence that I talked about at the beginning of this talk. So I think all of us are very familiar with the Tuskegee study of untreated syphilis in the Negro male, and we'll spend some time to talk about this. When we talk about historical mistrust, this is typically what we often think of. So this study was infamous for breaking trust via deception of hundreds of Black men. The study was driven by the conviction that a racial dimorphism existed for syphilis. And study participants with syphilis were denied treatment despite a known and available cure, an act that was both unconscionable and inhumane. So the study started in 1932. It was sponsored by the Public Health Service to record the natural history of syphilis, and it took place in Macon County, Alabama at the Tuskegee Institute. It included 600 Black men who were poor sharecroppers. 399 of them had syphilis. 201 of them did not have disease. The men who had syphilis were never informed of, number one, being in an experiment, and number two, they were never informed of their syphilis diagnosis. And Black men who ultimately died during this study underwent autopsies without consent from their families. The participants were offered medical care, food, transportation, medical exams, and survivor's insurance. And as you can imagine, as a poor sharecropper, if you did not know you were in a study and someone offered you these things, they were considered a godsend to them. The participants were told that they were being treated for bad blood, when in actuality, the treatment was withheld. Penicillin actually became the standard treatment for syphilis in 1947. The study was originally slated to last only 6 months, but it was conducted for 40 years until 1972, after a press leak led to a public outcry and the study's termination. Numerous Black men died of syphilis, 40 wives contracted the disease, and 19 children were born with congenital syphilis. This study, among other things, led to the National Research Act, which was signed into law in 1974. It created the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. It established guidelines for human subject research, and it provided oversight and regulation of human experimentation in medicine via the establishment of institutional review boards. Now let's move on to talk about Henrietta Lacks. So Henrietta Lacks was a Black woman who was diagnosed with terminal cervical cancer in 1951 after the birth of a child. She was actually treated at Johns Hopkins University, and her cancer cells from a biopsy were cultured by Dr. George Gay without her consent. These culture cells led to the HeLa cell line, which was the first immortalized human cell line and has been vitally important in medical research. After her death, additional samples were taken from her without consent, and the Lacks family actually was never made aware of the HeLa cells until 1975, when they were approached about providing additional blood samples. The HeLa cells have led to multiple medical advancements, including the development of the polio vaccine. It was the first cell to be successfully cloned. It was instrumental in developing the HPV vaccine, and the virologist who discovered this actually was awarded a Nobel Prize in 2008. HeLa cells are mass produced for biomedical research in cancer, HIV and AIDS, Zika, gene mapping, immunology, and the list goes on. By 2009, there were greater than 60,000 manuscripts that had been published on HeLa-based research. And since the 1950s, scientists have grown greater than 50 million metric tons of HeLa cells, and there are over 11,000 patents involving HeLa cells that currently exist. So clearly, HeLa cell use for medical and commercial purposes raises significant concerns about privacy and patients' rights. In fact, in the 1980s, family medical records were published without family consent. And in 2013, the complete HeLa cell gene was sequenced and published without the family's consent. Let's talk a bit about human radiation experiments. So from 1944 to 1994, there were over 2,000 human radiation experiments performed, and they were funded by the US military, Atomic Energy Commission, and other government agencies. And Black people were disproportionately overrepresented in these studies. Here in Cincinnati, We performed the Cincinnati radiation experiments from 1960 to 1971, and it was one of several radiation experiments funded by the DoD. It was done mostly on poor and Black cancer patients without consent for the first 5 years, and informed consent was questionable thereafter. It was led by Dr. Sanger, who performed total and partial body radiation on over 90 poor Black advanced cancer patients who were here at Cincinnati General Hospital, and Black patients represented 62% of study subjects. Concern upon subsequent review of this study was that many of these subjects had malignancies that were radio resistant, and he administered significant amounts of cobalt-60 within hours, which was comparable to 15,000 to 20,000 chest x-rays at one time. In terms of mortality, 25% of patients died within 2 months of irradiation, and greater than 75% of study participants died within the year. Now, I think the thing that is most disheartening to me is the experimentation of Black children, given my role as a pediatrician. So we're going to talk about 2 of these studies. So the Violence Initiative was a federally funded research initiative that was first announced in February 1992. And it was under the umbrella of the National Institute of Mental Health, and $400 million were allotted to this program. It was proposed as research into inner city violence, with the objective of identifying youth biologically or genetically predisposed to violence. Dr. Frederick Goodwin, who was at the time the head of Alcohol, Drug Abuse, and Mental Health Administration, suggested, as part of this violence initiative, a study be conducted of monkey behavior in nature and in laboratory settings as a model of how to deal with inner city youth. 3 experiments on children took place via the New York State Psychiatric Institute over 3 years that ended in 1996. And these studies were affiliated with Columbia University, Queens College, and Mount Sinai. Dr. Gales Wasserman and Daniel Pine actually led the NIMH-funded studies on Black and Latino children as young as 6 years of age. Both of them were affiliated with Columbia University. And Dr. Wasserman wrote, "It is proper to focus on Blacks and other minorities as they are overrepresented in the courts and not well studied." And they recruited a total of 128 children to participate in a series of studies. One of these studies hypothesized increasing serotonin levels may counter the alleged racially inherited genetic predisposition to aggressive behavior and violence. It involved 34 healthy boys who were between the ages of 6 and 10 years. White children are actually excluded from the study. Boys were all from poor families. 44% of the boys were Black, and 56% of the boys identified as Latino. But it's important to know that boys who identified as Latino were actually from the Black Dominican community in Washington Heights. So families were incentivized with money. Parents were given $100 in cash, as well as a $25 gift card for their child. And for the study, the boys were required to undergo exhaustive psychological testing, stop taking any other meds for 1 month, and that included meds for asthma, adhere to a high protein diet. They were required to stay overnight in the hospital, and during that time they fasted and underwent serial blood draws once every hour. They were given an IV dose of fenfluramine, which is the primary ingredient in fen-phen, which was a popular diet drug back in the 1980s and 90s, which was actually banned by the FDA in 1997 due to cardiotoxicity in adults. And before this study, this med had never been given to children under 12 years of age. What was particularly egregious about this study was in addition to all of these other things, was the role of informed consent. Potential study subjects were identified via the Department of Probation records, and subjects were actually the younger brothers of boys already involved in the criminal justice system. The use of this method to identify study subjects was clearly an invasion of privacy and a misuse of the criminal justice system. And as you can imagine, the coercion of parents who may have been worried about their child who was in the criminal justice system and the repercussions if they did not participate in the study had to be immense. The study's design certainly perpetuated the stereotype of Black boys and men as perpetrators of violence, a distorted and biased perception that continues to cost Black people their lives today. And it is a sobering example that even in the era of IRBs, welfare and protection of Black people who participate in research is by no means guaranteed. In fact, the Office for Protection from Research Risks, actually their investigation exonerated the research institutions that were involved with these 3 studies. The Baltimore lead paint study was actually conducted in 1993. And this study was conducted by researchers at Johns Hopkins Kennedy Krieger Institute, or KKI. And their study objective was to investigate the health effects of lead paint in children and determine the effectiveness of lower cost lead abatement techniques. Their target population were Black children in poor Baltimore neighborhoods, and this study was approved by Johns Hopkins IRB. 107 properties were categorized into 5 levels of abatement. KKI partnered with landlords in abating apartments with less expensive techniques designated by these 5 levels. The cost range for the less expensive techniques were between $1,600 and $7,000 compared to the typical cost of lead abatement, which was around $20,000 at the time. 75 homes were put into 3 specific categories, including 25 that got minimal repairs, 25 that got middle level repairs, and 25 homes that got more extensive repairs. And then they had 2 control groups, one in which all lead hazards were eliminated through the traditional abatement process, and then one in which houses were never exposed or lead paint was never used. The researchers actually found new families to move into these homes. 140 children were evaluated, and families were offered incentives to participate in the study. So the lead levels of children were measured periodically over 2 years to determine the effectiveness of various lead abatement techniques. And after the study ended, a number of Black children developed cognitive and neurologic sequelae from the lead exposure. There have been comparisons to this study to the Tuskegee syphilis study, given the targeted study group, which was 4 Black subjects, a lack of proper informed consent, as the study specifics were not clear or explicitly communicated to families. There was a lack of adequate care provided during the study, given that these kids had elevated blood lead levels. And then there was long-term negative impacts on study participants. And finally, I wanted to take the time to talk about the comparisons of research funding and initiatives related to sickle cell disease and cystic fibrosis. So I would be remiss if I did not talk about Dr. Gaston, who was one of our Cincinnati's finest. So in 1986, she published a groundbreaking study that showed the effectiveness of penicillin prophylaxis in children with sickle cell disease. It resulted in congressional legislation to encourage and fund sickle cell disease screening programs nationwide, and 46 states actually launched newborn screening programs within a year of the study. In 1990, Dr. Gaston actually became the first Black woman to be a director of a public health service bureau. So sickle cell disease is truly a myth of a Black disease. It certainly occurs in high frequency in Black people, but it is not an African American or African disease. Sickle cell disease is an evolutionary adaptation to malaria exposure. It occurs in higher frequency in people who live in regions where malaria is or once was common. Sickle cell trait is actually protective against malaria, and sickle cell disease is notable in other regions of the world or in other populations, including the Mediterranean basin, the Arabian Peninsula, and the Indian subcontinent. So this is a study that was published in JAMA in March of this year, looking at comparisons of US federal and foundational funding for sickle cell disease and cystic fibrosis. So when we look at sickle cell disease, we know that the US birth rate is 1 in 365 Black individuals, and that actually sickle cell disease was initially described in 1910, and it was the first disease with a known molecular and genetic mechanism. Cystic fibrosis occurs in 1 in 2,500 white individuals. It was initially described in 1938, and its genetic variant was not described until 1989. So when we look at sickle cell disease, both of these disorders are inherited and associated with intermittent disease exacerbations that require hospitalizations and with a substantial reduction in the median lifespan. We know that NIH funding is generally aligned with disease burden based on disease prevalence, severity, and age of onset. And we know that there are complex sociological factors that contribute to how private medical foundations generate revenue to fund advocacy and research. And these diseases disproportionately impact very different populations and have very different research funding profiles, with this, which this paper outlined very well. So looking at sickle cell disease, from 2008 until 2018, 90,000 individuals had this diagnosis. During the same time period, 30,000 individuals had the diagnosis of CF. So CF has the prevalence of 1/3 that of sickle cell disease. However, when you look at mean NIH funding and mean philanthropic expenditures, you see the numbers there for sickle cell and how they are vastly lower than those numbers for NIH funding and philanthropic expenditures of those for sickle cell initiatives. In terms of publications, there were 926 publications related to sickle cell disease in a 10-year time period, compared to nearly 1,600 publications for CF. And then looking at sickle cell, there are 2 disease-specific drugs on the market, 1 disease-specific drug in development, and for cystic fibrosis, 6 disease-specific drugs and 4 disease-specific drugs in development. I think the thing that is most striking to me is access to quality comprehensive care. So looking at sickle cell disease, there are no federally supported centers for comprehensive sickle cell care. Funding for the 10 centers that did exist actually ended in 2008. And any existing sickle cell comprehensive centers depend on institutional support. Reimbursement for these centers are generally low due to the fact that most individuals with sickle cell disease are publicly insured. And adaptation of best practices is variable, even though evidence-based guidelines certainly exist. In contrast, for cystic fibrosis, we have the established Cystic Fibrosis Foundation, which encompasses research funding, accreditation of comprehensive CF centers, and implementation of national quality of care standards. We have over 120 comprehensive CF centers around our country. And we have a CF National Patient Registry to evaluate the adherence of guidelines, benchmark CF centers, and provide data for QI efforts. So the question becomes, where do we actually go from here? I think education is paramount, and I would strongly recommend 2 books on this list. Medical Apartheid by Harriet Washington, I think, is a must read for every physician, and then The Color of Law. I think we have to address racism in medical education. We have to focus on health equity, anti-racism, and social determinants of health. It is vital to appreciate how marginalized communities experience economic, housing, education, and environmental equities. These are all factors core to our health and well-being as citizens. We have to halt practices that promote scientific racism and race-based medicine. We have to address the hidden curriculum of medicine. What we implicitly teach actually truly matters. And we have to make diversity and inclusion a priority. Diverse teams optimize our research priorities and the care we deliver to our patients. This was a paper that was just published in Health Affairs last month. entitled On Racism, a New Standard for Publishing on Racial Health Inequities. And this paper truly called out the need to call out racism, not mistrust as the primary obstacle between Black patients, health equity, and excellent health outcomes. We have to be explicit about the role racism plays in impacting health outcomes and research publications. We have to acknowledge that Black patients' mistrust of the healthcare system is not the cause of health inequities or disparities. Mistrust is a result of historical mistreatment, which is what I tried to outline today. And then they gave recommendations on publishing on racial health inequities. We have to define race during study design and specify the reason for its use. We have to talk about the definitions of race appropriately. So race should not be defined by biologic or genetics, but we should talk about it from a socio-political standpoint. We have to name racism, its form, its mechanism of operation, and other intersecting forms of oppression. We have to solicit patient input such that research reflects the priorities of our study population. We have to identify the stakes. All policy is certainly health policy, and we have to cite the experts, particularly scholars of color. And I will end with this quote from Dr. King: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I am hopeful that we are at a point in our country, we are at a point in medicine where we can really make a difference for future generations. Thank you all, and I'm happy to take any questions.
Thank you, Ndidi. This was an amazing talk. I always feel like I learned so much in your presence, so I appreciate your time. We do have some time for questions. I do have a few comments that I definitely want to say. This has been a fantastic presentation. Thank you so much for sharing this incredibly important information today and for your leadership in the area. Somebody also I want to say, and I believe this came from Prasad, I might suggest that CCHMC has been leading the research and cure for sickle cell disease nationally and internationally, thanks to the amazing work of many of the individuals that are here.
Yeah, I would agree with that for sure.
Let's see. Many people have phenomenal presentation comments about how they're very appreciative of you raising their awareness. I'd like to go back to what CCHMC is doing. So what are we not doing that we need to be doing? We'll focus on the area of sickle cell, for example.
Yeah, you know, I really do think here at Cincinnati Children's, we provide excellent sickle cell care. And I think that has been, that has resulted in the number of patients that we see admitted to the hospital for sickle cell disease dramatically decreasing. I think we have wonderful leadership. I know Lori Crosby is on the line, and I think she has done an amazing job. Russell Ware, Pat McGann, so many physicians here at Children's who are really dedicated to the care of our sickle cell population. I think it would be really important to try and advocate for a more substantive approach across the country, similar to what we do for cystic fibrosis. I think it's shocking that sickle cell disease is far more prevalent, but the resources to really build an infrastructure, do data sharing across the board to really try and positively impact the outcomes of that patient population. I think it's a miss, and I think advocacy in that area is definitely warranted.
And do you know if the funding at Cincinnati Children's for sickle cell is mirrors the funding that CF gets?
That I don't know. That I am not sure of.
So one question here. What is your suggestion on how to integrate systemic racism in healthcare in a classroom setting?
Yeah, you know, I will say, you know, as a med student, we never talked about this. And so I do think that we are in a different era, and I think it's important to have these conversations. I think we need to be mindful what we teach our medical students. We need to be more inclusive of what we teach as it relates to physical exam findings, how we assess for things on like rashes, and making sure that we are truly inclusive of the examples and the pictures that we share. I think it's time for us to really make a pivot from having students present patients and starting off those presentations by talking about the race of the patient. I think we have a lot of work to do in that area. I think as it relates to structural racism, we have to acknowledge that our patients and families who come from marginalized communities, what they experience outside of these walls impact their health. And I think if we don't take a more holistic approach to our patients and families, we are doing them a disservice. And I think, you know, us talking about the non-compliant or the non-adherent patient and thinking that that is the end result rather than a symptom for something greater is our fault. We have to dig deeper to figure out why aren't our patients non-compliant? What are some of the societal influences that really inhibit them from doing the things that we think are necessary for them to be healthy?
So along those lines, or sort of interrelated, how do you hold your peers accountable when you witness systemic racism, or do you feel like your actions are limited?
You know, I think that in my role, I think part of it is being willing to have these discussions and really bring awareness to the table. I think really being able to speak truth to power. I think structural racism is a big thing, right? I think this is something that has been established and been in place for hundreds of years. But I think if we don't call out the specific policies that continue to exacerbate the problem, we won't get anywhere. You know, I think the various levels of racism on a daily basis, when we see things that might be consistent with bias, it's really our job to speak up. And I think it's important, particularly for our trainees, such that they model what we do as physicians, nurses, social workers, psychologists. And it's important for our families to know that we are actually in their corner and that we recognize what they are going through on a daily basis.
Okay, I have one more question here for you. Lots of comments still are coming in. This question, you might actually find it a little harder.
Sure.
What about discussion within the medical community around medical reparations for the harm that's been caused?
You know, I think that is, I think those discussions about reparations are happening. And I don't think the medical community should be separated from those conversations. I think what we need to think about is like how does that actually get implemented? What does that mean for our patients and families that have been exploited and abused in the past? And I think we have examples of like these, you know, victim compensation funds, which I think are fine, but it doesn't really make up for the divestment in certain neighborhoods. And we as an anchor institution in a neighborhood like Avondale, what is our role in, you know, trying to build and bolster this neighborhood for the patients and families who live here and seek out our care? So I think it's a relevant question.
Okay, well, this has been a phenomenal talk. Some of the final comments before we get off, we're sharing this with the leadership at least at Cincinnati Children's, but I'm gonna say leadership across the enterprise, so of the Academic Health Center, both here and across the street, because this is an amazing wealth of information that I think we need to be reminded of over and over and over again until this is a part of the history that we know well. Other people have, and I agree, have also suggested that this become part of our required training, as is integrity training and safety college and all of the things that we have to go through. This should be integrated into that, because then we will learn it every year over and over again. So I want to thank you again for spending the hour with us and teaching us something that is just heart-wrenching and fascinating, and hopefully will help us all move forward. So thank you.
Thank you for having me, and thank you everyone for joining. I really appreciate it.